in general, if they're between 1 to 49%, I think chemo plus immunotherapy is the standard of care. But I've had several patients in their 80s that just don't want chemo. I personally don't think they're fit enough for chemo. So my personal opinion or their preference. And prior to the FDA approval for monotherapy alone, I've even had to get free drug for these patients with immunotherapy alone. But now it is FDA approved. And so I've just treated them in immunotherapy by themselves. They've actually done quite well. So I do think there's a role for that, even though my preference is to give them both chemo and immunotherapy if I thought they could tolerate or if they, and they wanted it. And so I think there's some flexibility there, but again, our job is to tailor it to each particular patient. So that's one example. Another example would be a patient that's a very high biomarker, PD-L1 50%, but they're super sick. They have a high burden of disease. I know I need to get a quick response rate, even though it seems like the survival is pretty similar in that population between immunotherapy by itself and chemo and immunotherapy. We know the response rates are higher by doing chemo immunotherapy. So in that case, even though they have a PD-L1 greater than 50%, I would still probably give them chemo immunotherapy to try to shrink down their tumor so they can feel better.